Welcome to Healthcare Channel. Helicobacter pylori, H. pylori, is a gram-negative bacterium that colonizes gastric mucosa. It is a major human pathogen associated with chronic gastritis, peptic ulcer disease, gastric adenocarcinoma, and mucosa-associated lymphoid tissue, MALT, lymphoma. In this video, we will discuss the pathogenesis, clinical manifestations, and treatment options for H. pylori infection. The pathogenesis of H. pylori infection is complex and multifactorial. The bacterium colonizes the gastric mucosa by adhering to the epithelial cells and by producing urease, which converts urea to ammonia, creating a favorable pH environment for the bacterium to survive. H. pylori also produces several virulence factors, such as BACA, CAGA, and DUPA, which contribute to its pathogenicity. BACA is a cytotoxin that induces apoptosis of the epithelial cells, disrupts the tight junctions, and inhibits the secretion of gastric acid. CAGA is a protein that is translocated into the epithelial cells, where it alters various signaling pathways, leading to inflammation, proliferation, and cell transformation. DUPA is a protein that is associated with an increased risk of duodenal ulcer and decreased risk of gastric cancer. H. pylori-induced chronic gastritis is characterized by infiltration of the gastric mucosa by neutrophils, lymphocytes, and plasma cells. Chronic inflammation leads to the destruction of the gastric glands and the loss of parietal and chief cells, resulting in hypochlorhydria or achlorhydria. The loss of acid secretion leads to an increase in gastric pH, which further promotes bacterial colonization and growth. Clinical manifestations. H. pylori infection is usually asymptomatic, but it can cause various clinical manifestations, depending on the severity and duration of the infection. The most common clinical manifestations are dyspepsia, epigastric pain, and nausea. These symptoms are usually mild and intermittent and may be aggravated by certain foods, such as spicy or fatty foods, or by alcohol and tobacco use. H. pylori infection is also a major risk factor for peptic ulcer disease. Peptic ulcers can occur in the stomach, gastric ulcer, or the duodenum, duodenal ulcer. The clinical presentation of peptic ulcer disease is characterized by recurrent episodes of abdominal pain, which may be relieved by food or antacids. Complications of peptic ulcer disease include bleeding, perforation, and obstruction. H. pylori infection is also associated with an increased risk of gastric adenocarcinoma and MALT lymphoma. The risk of gastric cancer is highest in patients with atrophic gastritis, intestinal metaplasia, and dysplasia, which are precancerous conditions that develop as a result of chronic inflammation and tissue damage. MALT lymphoma is a rare type of lymphoma that arises in the gastric mucosa and is associated with chronic H. pylori infection. Treatment. The treatment of H. pylori infection involves the eradication of the bacterium using a combination of antibiotics and acid suppression therapy. Treatment aims to achieve a cure for the infection and to prevent the development of complications, such as peptic ulcer disease, gastric cancer, and MALT lymphoma. The current guidelines recommend a triple therapy regimen consisting of a proton pump inhibitor, PPI, clarithromycin, and amoxicillin or metronidazole for 14 days. PPI is used to suppress gastric acid secretion, which enhances the activity of the antibiotics. Clarithromycin and amoxicillin or metronidazole are used to eradicate the bacterium. However, the efficacy of triple therapy has declined over the years due to the emergence of antibiotic resistance, particularly to clarithromycin. Therefore, it is important to perform antimicrobial susceptibility testing before initiating treatment to guide the selection of antibiotics. In cases where clarithromycin resistance is present, a bismuth-based quadruple therapy regimen may be used instead. This regimen includes a PPI, bismuth subsalicylate, tetracycline, and metronidazole or clarithromycin for 10 to 14 days. Bismuth subsalicylate has antimicrobial and anti-inflammatory properties and can enhance the activity of antibiotics. In cases where both clarithromycin and metronidazole resistance are present, a levofloxacin-based triple therapy regimen may be used instead. This regimen includes a PPI, levofloxacin, and amoxicillin for 10 to 14 days. Levofloxacin is a fluoroquinolone antibiotic that has good activity against H. pylori and is less affected by resistance. Other treatment options for H. pylori infection include sequential therapy, concomitant therapy, and hybrid therapy. Sequential therapy involves a 5-day course of a PPI and amoxicillin, followed by a 5-day course of a PPI, clarithromycin, and metronidazole. Concomitant therapy involves a PPI, amoxicillin, clarithromycin, and metronidazole for 10 to 14 days. Hybrid therapy involves a 7-day course of a PPI and amoxicillin, followed by a 7-day course of a PPI, clarithromycin, and tinidazole. After completion of treatment, follow-up testing should be performed to confirm the eradication of the bacterium. This can be done using a urea breath test, stool antigen test, or biopsy-based tests. If eradication is not achieved, a second-line treatment regimen should be initiated. In conclusion, H. pylori infection is a major human pathogen associated with chronic gastritis, peptic ulcer disease, gastric adenocarcinoma, and malt lymphoma. The pathogenesis of H. pylori infection is complex and multifactorial, involving bacterial colonization, virulence factors, and chronic inflammation. The treatment of H. pylori infection involves the eradication of the bacterium using a combination of antibiotics and acid suppression therapy. The choice of treatment regimen should be guided by antimicrobial susceptibility testing and should be tailored to individual patients. Follow-up testing should be performed to confirm the eradication of the bacterium and to prevent the development of complications. Thanks for watching. Subscribe now for more information.